Hey guys, so in this video, we're going to focus on Train the Trainer for the messy airway mannequin. Now, let me apologize ahead of time. Like I said earlier, I don't have access to any of the Airway equipment to actually physically show you guys how I would use it. So I'm going to have to do mimicry with the hands, provide some pictures in the notes, and use your imaginations, unfortunately. So as far as creating a messy airway mannequin, I'm going to see if either Regions EMS can loan out the airway head, or if Kent or someone in the office can provide directions, like make a video on how to create the messy airway mannequin. That way you guys have access to it. With an airway, we're going to start with BLS airways, through ventilation, through supraglottics, through intubation. So I start with asking clinicians, how do you size an NPA? And the answer should be, right, from the nair to either angle of the jaw or the earlobe. They're the same spot, so it doesn't really matter how they answer that specifically. And then I ask, why do we teach bevel towards the septum? And most people just say, oh, it's because how it's curved. Well, I can put an NPA in right or left nair, doesn't matter, so it can't have to do with the way it's curved if bevel's always towards the septum. If you look at anatomy of the nose, you only have two places that are vascular. You have the septum, and you have this cartilaginous ridge. If I put the only pointy part of my NPA towards the most vascular part of my nose, I'm more likely to cause swelling and bleeding. So our goal is to avoid that. Angled area or bevel towards the septum should limit the chances of perforation, bleeding, swelling in the nose. Second hang up I see with clinicians. Once I get that NPA past that nair opening, I do not continue to follow the angle of the nose. What I should be doing is turning it back towards the spine and pushing it straight back. That way my NPA actually goes through the nair opening of the skull. If I go up and you notice that you're hitting a lot of things and having to twist it in, it's because you're getting it caught on cartilage. And if I keep twisting and pushing it in, I'm probably going to cause bleeding and swelling, which again makes my job harder, and I would like to avoid that. If you have patients that are appropriately sized for an NPA, but your clinicians are still having troubles we're going to get for some patients, aim for the left nair over the right. 70% of patients' left nair is mildly larger, so it should be a little bit easier to place. There are a few studies now that have come out that said if I can get one NPA, I should actually attempt two NPAs, because I can move almost as much air ventilating a patient with two NPAs as I can with one OPA. So you got the patient with the clenched jaw, and I dump two NPAs, I can effectively ventilate that patient. You should go ahead and attempt to do so. OPA placement, right? Corner of the mouth, angle of the jaw. Excuse me. There are a few ways to place an OPA. I have it in the notes that there are three specific techniques. The technique that most of us are most familiar with, right? Up towards the top of the mouth, back, turn 180 degrees down to the airway. There's a few studies that have shown that is the best way to cause damage to soft and hard palates while placing an airway. In fact, it's one of the only ways we can do it while placing an oral airway. So I would look at the two other ways to place an airway. Easiest one, my opinion. Take your OPA. Instead of going up, I go towards the cheek. And as I push my OPA back towards the cheek, when I get to the back, I turn 90 degrees down into the airway. Unless your patient has some kind of weird snaggletooth or something to get that OPA caught up in, there's nothing solid along the cheek to catch and cause damage to. So even if I'm a little aggressive in pushing that in and then turn, I can't hit anything solid. I'm not causing damage to anything but some minor epithelial cells. I won't cause bleeding or swelling. The other way to do it is to utilize either a tongue depressor, your thumb, or the way I do it, I will grab a slightly smaller OPA, and I put the size smaller OPA to catch the tongue and teeth to hold the tongue down so I don't occlude by pushing that tongue back. And I just forward my normally sized OPA right over the tongue, following the angle of the mouth. For ventilation purposes, Regions EMS does not suggest utilizing a one-handed mask seal with a BVM. There are going to be times, however, when you walk into a scene, you didn't realize the patient is going to need BVM support, and you might only have one person available while the other partner is going to grab more equipment, while you guys are calling for additional resources, while that partner is doing something else for the patient that's also life-saving. So if you have to hold a one-handed mask seal even for a limited amount of time, Most of us have been taught to use that C-E grip. C around the mask, E around the jaw, and you pull up. Recent studies have shown with our newer BVM masks, by pushing down on one side of that mask and pulling up, the masks are so soft that I actually lose a seal on the opposite side of that mask. I have a leakage in there. Maybe a better way to hold it one-handed is instead of a C on the top of your mask, you do an O on the top of your mask and you hold it right around the top port. And you put pressure down in the middle of your mask and then pull up that jaw. They've shown that you have much less mask leakage and better ventilation support. Still pull up that jaw with the E grip, same 3 fingers, okay? Two-handed mask seal. CE grip is fine. The only problem that they've shown with them is that your hands can cramp up rather rapidly. Usually less than a minute, you'll start having some fatigue and a potential for mask seal leakage. A few people have shown that you can hold a seal longer using what's called a VE grip. I have a picture in the notes on how to do this, but it's extraordinarily simple. If I have my mask right here, I take my thumbs, I make a V, and I push down on the top of the mask while pulling up the jaw with my other fingers. I think it's easier to do. I've noticed that I can hold it longer. I also read studies that said that I would be able to hold it longer prior to attempting the VE grip, so maybe that just got in my head that it would be easier to do, and now I feel like it is. But I would say try it. If you guys like the VE grip, train with the VE grip. If you guys don't, it's fine. The CE grip works just fine as long as you're doing that double-handed seal with it. So I would have your clinicians practice one-handed and two-handed with the VE, and actually have someone ventilate and do it for about, ventilate 20, 30 seconds, make sure they're comfortable holding the seal, make sure they have a good mask seal. And that's what I would do at the end of this, right? I would talk them through all of this first before I have them actually get hands-on with any of it. I've noticed that it ends up saving time in the end by getting all the questions out of the way ahead of time. Sorry, I should have mentioned that at the beginning. So after BVM, let's talk about iGel. So a lot of people, when I ask, how do you size the iGel? They say it's weight-based. And they base it on the fact that the weight is on the end of your iGel. It'll say the kilogram weight of the patient, and they judge it on that. So I usually ask the clinicians, if I have a 5'8", 200-pound male, what size iGel do they get? And they usually say a 4 or a 5. I say, great. I have a 5'8", 600-pound male. What size iGel do they get? The patient's anatomy didn't get any longer. It just got wider. So ultimately, patient weight is not how an iGel is sized. iGels are sized by ideal body weight, which is really just based on patient height. So when we're trying to decide what size iGel to utilize in a patient, we should be looking at the height of the patient, not the actual weight of the patient. Sorry about that. I ended up shaking the table a little bit. My apologies. When you place the iGel, remember you're only lubing the back of the iGel. If I lube both back and front of it, it will not create a good seal inside the airway. Use something to pull that tongue out of the way. My favorite way, I've never placed an iGel without already having an OPA in place in the patient because I need to make sure they didn't have a gag reflex. Instead of taking that airway out, instead of removing the OPA entirely, I use the OPA to catch the tongue and teeth on the way out and hold that tongue out of the way so I can forward my iGel over it. I haven't had any problems forwarding an iGel using that approach to it. Once you feel resistance while pushing the iGel, stop, start bagging. If you find that you get not great lung inflation, I treat the iGel a little bit like a king airway. Well, I'll pull back slightly while bagging until I get better chest inflation. And if I end up pulling the iGel all the way out of the airway while doing that, as long as I don't touch other things with it, right? Wipe off the iGel on the bench seat next to me, I can put it right back into the airway and make it a second attempt at it. It doesn't take a lot of time. You can effectively ventilate once you get the iGel in place. Now, before I talk about intubation, the other thing that this station really focuses on is suction. So before I go to the intubation airway, I talk a little bit about suction at this point. So if we were to take a national registry exam today and your medics needed to pass it, and I asked, how long can you suction an airway before you ventilate? The national registry answer is still 10 seconds. So imagine for a moment, I have a patient with an airway full of feces and blood and vomit. And I go, well, I should probably suction that. And I suction for 10 seconds and they're still gurgling up feces and blood and vomit. I can't go, no, we're at 10 seconds, time to ventilate. As if I do, all I'm going to do is shove all that directly into the lungs. I go from a potential aspiration to bagging that directly into the lungs and causing an absolute definitive aspiration. An aspiration pneumonia has about an 80% mortality, so we should avoid that. The true answer, to back up a second. The study that said 10 seconds, the 10 seconds isn't wrong. 10 seconds came from a study based on patients that were already intubated. So if I'm already in the lungs and I see stuff that's in the lungs coming up my tube and I start suctioning, my goal is not to clear the lungs. My goal is to clear the tube. So I should be able to clear the tube within about 10 seconds. And if I can't, I have a problem where I might have an occlusion of that tube. The odds are I'm not going to go ahead and suction out the lungs in 10 seconds. So that goal is to just clear your tube so I can effectively ventilate into the lung skin. The answer for your BLS airways are I should suction until I have a clear airway. Now, I can't obviously suction for 3 minutes without ever giving oxygenation or ventilation. What I want you to think about is I start suctioning and I have an acute amount of stuff in the airway, right? It's not continuously bubbling out. They're not continuously vomiting. I just had some in the back of the throat. I suction out, I start bagging. That should take me 10 to 15 seconds. It's clear. I bag with a BVM. Great. If they're continuously vomiting or I keep seeing secretions being created, well, I'm suctioning and I realize I'm getting to 5, 10, 15, 20 seconds. I have to start looking at my partner and say, could you go ahead and get the intubation equipment ready? Because if I have a patient that's continuously vomiting or continuously creating some kind of airway fluid, whatever that happens to be, I'm not going to be able to use a basic life support airway for this patient because I'll never have a clear airway. So if I'm taking an extended period of time to suction, I should be prepping for intubation for that patient over BVM or iGel. If I have that acute amount of fluid, I suction, it's all gone, I would go back to my BVM while a partner is then prepping for an iGel. So let's say I bag 10, 20 seconds with a BVM while my partner's getting the iGel ready. If I haven't had to suction a second time, I'll go ahead and place the iGel. If on the other hand, while I'm bagging, my partner's getting the equipment ready, I see more gunk in the back of the airway and I have to suction a second time, I would just go for intubation because I don't know how many times I'm going to have to keep clearing that airway, but I know that I'm going to get more effective ventilations, popping the intubation tube, filling that cuff up, and then suctioning around for the esophagus, but I know I'm getting air into those lungs. The point of a messy airway station is that we're going to have a patient that is continuously vomiting while placing your intubation. There's a number of studies now out that are comparing bougie versus stylet. I want you guys to remember that your EMS medical direction team wants you to use bougie for all first-time intubation attempts. First pass intubation, any airway. Bougie is 98% effective. Stylet was, I think it was 87% effective. For a messy airway, bougie remains at 96%. And bougie dropped to mid 80s, I think. So it's not like it dropped it that much farther. But if we're talking, I have 96 out of 100 patients that got intubated on the first time versus 82 to 84% out of 100 first time attempt. I'm going to take the 96. I really like the stylet. I always feel better intubating with the stylet. But science does not care about my opinion. Science says the bougie is easier to use for intubation than a stylet and more effective. So it's what we're going to practice with. We are going to utilize something called salad intubation, suction-assisted laryngoscopic airway decontamination. Or you just suction the whole time that you're attempting to intubate. So when I have to intubate this patient, the first thing I'll do, and understand when I'm teaching this, I will not have anything in the airway yet. I'll just get all my equipment ready and show them how I want them to do it without a messy airway yet present. I make the airway messy once they start attempting to intubate. So first thing you should do, turn on your suction. Get all your equipment ready. The first piece of equipment that passes the patient's mouth is my suction catheter. So I have my laryngoscope blade. I have my suction catheter. I'll mirror this for you. So suction, right? This should be in my right hand, blade in my left hand, right? The suction is being used as a tongue depressor. I'm moving the tongue out of the way, I'm lifting a little bit, and I'm forwarding that suction. And what I'm looking for is, am I pulling anything out of the airway? And the reason I'm doing suction first is because if I do my blade first, and I lift up, and I find there's a bunch of gunk on the end of my blade, I just really destroyed my view by covering that camera. So while that's pretty useless, I do the tongue depressor, I lower that to start suctioning. If I'm suctioning a lot of gunk, I'll suction until I can get this in clear. And as soon as I go ahead and see those cords, I move my suction to the other side of my blade without taking my eyes off of those cords. And the reason I'm doing that is because if I leave it on this side of the blade, I'm just going to have another tube that's in the way that's blocking my view of those cords for effective first-time intubation. So I move it out of the way, I push it down a little bit, and I can let it continue to suction on its own hands-free. This works with a decanto suction, because decanto, you don't need to put a finger over that air hole like you would on a Yankauer. It'll just pull continuous suction for you. If you happen to carry a yank on your truck, or you haven't changed to decanto, or you're trying to use all of your equipment that you currently have before getting a decanto on the rig, you can place tape around that open porthole on your Yankauer, so it'll always have something occluding that, and thus it'll now pull continuous suction. So it'll work even with a yank, you just have to adjust it mildly. So I have my blade in, I have my suction over here. I have somebody hand me my stylet. I go ahead and put the stylet in. I continue watching those cords. I have my partner go ahead and put the, my tube on. Forward that. I tell them to hold the bougie, not remove the bougie. Once I've got the tube in place, I'll have them now fill the cuff. After they've filled the cuff, then I will have them go ahead and pull the bougie while still watching those cords. And after the bougie's out and my cuff is filled and I still verify them in the cords, then I can go ahead and remove my blade and have my partner start bagging. Suction is still in the airway, still pulling fluid. We do it this order, and we leave suction in for a couple reasons. The reason we're doing this order, I have seen both in practice and in reality. If I use a bougie and I forward my tube and they pull the bougie out violently, besides getting vomit all over my face, which I don't enjoy, pulling that bougie out has a chance to actually catch the end of my tube and displace it back out of the airway, which means I get to start all over again with my intubation attempt. So I want that tube to be in. Obviously, if they pull the bougie before my tube is even in the cords, I have a much bigger problem also. But once the tube is past the cords, I want you to now fill the cuff, because that'll better seat that tube inside the airway, less likely to get pulled out. And then I continue holding that in place when they pull the bougie out. Since the bougie has that little angled part at the end of it, I don't want it to hook the tube on the way out. And then I'm still watching and verifying. I pass the cords and through the cords, everything's in, suction is working effectively, we can ventilate effectively, and I pull that out. So I've technically occluded the lungs by filling up the balloon on my intubation. There are a couple of older studies. We're looking 2008 to 2011 that showed that post-intubation attempt, a number of studies show that they could pull out gastric juices from the lungs. And this occurred in about 60 to 70% of patients that were post-intubation. Now, what that means is the patient aspirated. That they can't verify is if the patient aspirated prior to intubation attempt, or if some gastric juices and vomit actually leaked around the tube cuff and still ended up bad down into the lungs. Since we've already talked about that aspiration pneumonia is bad, 80% mortality rate, we want to limit that as much as possible. So leave your suction going to keep that airway as clear as possible to limit the chances of aspiration for this patient. Then go ahead and tie everything down, answer any questions that come up. After I show the clinicians all of those things and talk through it all, then I set them loose to do it. Everybody places NPAs, everybody places OPA. Everybody will use a one-handed and two-handed mask seal on a BVM. Everybody will place an iGel effectively. And then I start the vomit. And with the vomit going, I will usually do that with the iGel currently in there so they can start seeing it bubbling around. They usually feel that they're having trouble ventilating. Pull that, begin suction, appropriately use satellite technique for intubation. Move on with life. I would do my best to find a good video that shows salad intubation. I found a couple of videos that use equipment similar to ours, but not the exact equipment that you guys carry in your rigs. So I'm still on the hunt for that. If I find one that's exact, I will provide it to you. If I don't, I will provide the best videos I can find showing the actual salad technique. All right. I hope that helps. If you guys have questions, email or call me. I will see you on the next video.